Everything okay, right?
Yeah,
Can hear, no?
can hear.
Hari, okay, right. Shall we start then?
Yes.
Okay. Right. So today is part 2 of neurology. And again, this is theory, right? And I think on Sunday, we'll just breeze through the clinical stuff. And I'm not going to spend a lot of time explaining the clinical neurology again, apart from a few areas, maybe 1 or 2 areas. So I think I want everybody to just revise all your neurology short case classes that we've done and everything in preparation for Sunday, where I'm not going to do a lot of explanation because I've done this several times, explaining the short cases, how to localize lesions and things. So we'll just focus on the MCQs and just bang through them rather than spending a lot of time. So I need you to do some revision today and tomorrow, okay, in preparation for Sunday. But today's sort of pure theory stuff as well, yeah? Right. Hi. Oh, that's good. All my Oxford medical students have passed the exam. Sajit may had it again and it did not pass it. Okay. Right. Good. Right. So right now here in the field of seizures and epilepsy, the classifications are slightly confusing, right? So I just want to give you the classification so that you don't mix this up. Okay, right. So essentially, a seizure is a paroxysmal event. Paroxysmal can without warning. It means that there is without warning a manifestation that occurs due to abnormal, excessive hypersynchronous. The word hypersynchronous is all the neurons fire together, right? All the neurons fire together. So that is a electrical event that manifests with some neurology, right? So that is what a seizure means, right? Epilepsy is the chronic tendency to manifest recurrent unprovoked seizures. Unprovoked seizures, for example, they don't have any obvious cause for the seizures. Say something like hyponatremia or infection. Seizures epilepsy. Now, some of the epilepsies, say people who would manifest recurrent seizures, can be put into a box, which is called an epilepsy syndrome. Epilepsy syndrome. Right? Epilepsy syndrome. And an epilepsy syndrome has a very specific clinical profile, and also it may have specific EEG patterns. So it has a very specific clinical profile. There may be specific EEG patterns, and there may be MRI or imaging abnormalities in association, right? So that is what you call an epilepsy syndrome, or a very specific diagnosis, where there is a very specific clinical presentation, where there is a very specific EEG abnormality, and maybe some changes on radiology, like MRI findings, right? So that is what you call epilepsy syndrome, right? Epilepsy syndrome. Hi. Now, the classification of seizures has changed quite significantly over time. At the moment, this is the sort of accepted classification. So currently, we classify seizures into focal onset, generalized onset, and unknown onset. Right? So what am I classify currently? Right? So focal onset, generalized onset, and unknown onset. And within the focal onset, some of the focal seizures, the consciousness is preserved, and some of the focal seizures, consciousness is impaired. Right? Consciousness is impaired. In the old terminology, complex partial seizures so focal onset seizures with impaired awareness were called complex partial seizures. That term is going out of practice now, right? That's no longer used in the classification. Right? So that's how you sort of classify seizure: focal onset, generalized onset, and unknown onset. Right? Focal onset can be where the consciousness is preserved and patients might have impaired consciousness. And focal onset seizures can be further classified based whether it's motor or non-motor. Right? Okay. Classify. Fine. Okay, this is not very important for the moment. Hi. So let's go to the MCQ. Right. Now, if you take causes of seizures, right? Causes of seizures. This table gives you a rough guide to the causes of seizures. Right? Causes of seizures. Right. So seizure, remember, is an abnormal paroxysmal event due to hypersynchronous overactive discharge of neurons. Right. Okay. So this just gives you a list of the causes of seizures, right? And that's based on age of onset. Cerebrovascular, so first statement, cerebrovascular disease accounts for most seizures occurring after the age of 65. That is absolutely true, right? It's the commonest cause in elderly people, right? Commonest cause in elderly people is underlying cerebrovascular disease, right? Penetrating head trauma, head injury is another important risk factor for seizures. Now, both of these things, why they cause seizures is because there is scarring in the brain. So when there's an infarct, there is scarring in the brain. When there is some brain damage due to head injury, there is scarring in the brain. So that is why they develop seizures. The scarred area acts as a focus, right? And starts firing off like crazy. Hari. Okay. Hari. Now, the third statement is rather difficult, and I would say I would now remove this. I would not ask this statement now from you because with time, so at the moment, a genetic predisposition is recognized for most patients with epilepsy with Varadi, but obviously with improving genetic techniques, sequencing methods improve, we are identifying more and more genetic predispositions to people who have epilepsy. So epilepsy is these recurrent unprovoked seizures. Then at most people, there are some people who have a genetic predisposition, but ඒක හරියට කියන්න බෑ. ඒක හරියට statement එක කියන්න බෑ. හරි? Because we are still identifying a lot of genetic predispositions. හරි. The fifth statement is also important. Sleep deprivation may precipitate seizures. That's true. Apart from sleep deprivation, Lamai, apart from sleep deprivation, fasting is also one of the common precipitants of seizures. Also fever, right? So these are some of the common precipitants of seizures. So here just seizures and epilepsy etiology. MCQ we are talking about. Right. Okay. Now, when you're diagnosing a seizure, the clinical history is very important. I would say, based on my experience, the clinical history is the most important thing to diagnose a seizure. The most important thing. So in the exam, we will obviously test your ability to clinically diagnose a seizure. Because the clinical history is very important, right? Probably the most important thing. Now, in the next slide, I have given you a table which compares a seizure with other conditions that can mimic a seizure, right? And that is syncope. So vasovagal syncope, cardiac syncope can sometimes mimic a seizure. Now let's go through this MCQ. So here we are looking at features that suggest a seizure over vasovagal syncope. Vasovagal syncope. Sorry. Number one, emotional stress prior to the episode, right? More towards syncope, right? Vasovagal syncope, more towards that emotional stress. Also, when they have been standing in the sun for a long time, right? Sweating in cramped places, that also would be more suggestive of a vasovagal attack. Right? Now, when you have a syncopal episode, the typical presentation is they have sort of tunneling of vision. Tunneling of vision is also more suggestive of a syncopal episode, right? More suggestive of a syncopal episode, right? Now, if you take the very important features that are strongly associated with a seizure, the first thing I would say is injuries. Lateral tongue bite. So lateral tongue bite is one of the important things that actually suggests a true seizure. Lateral tongue bites. And cheek biting. Lateral tongue biting, cheek biting. And injuries. These are more suggestive of a seizure than anything else. Right? So lateral tongue bites, and also incontinence, right? Urinary or fecal incontinence. A seizure that would suggest more seizure than anything else. Right? Okay. That's the second thing. Last thing is this post-episode confusion or post-episode drowsiness, right? Is more associated with a seizure. Post-episode confusion, post-episode drowsiness, and also post-episode amnesia. What happened, the patient can't recall, right? Post-episode amnesia. Whereas a patient with syncope will remember a little bit leading up to the event and also something that happened during the event also. But a seizure patient will never be able to recall that. Right? So post-episode symptoms like confusion, drowsiness, amnesia are more strong suggestions that this might be a seizure. Right. So api palawani එක false, devani එක false, tongue cheek biting, yes, post-episode confusion, these are more seizure. Now, last thing to remember is, you can have some non-specific jerks during a syncopal episode. Non-specific jerks. And sometimes might look like seizure activity. Why this happens is, especially if you have a vasovagal episode, dannati manusek na mokada karanne? Ila tag gala patient ne vaadi karawanna hadawane. So if you have a patient who has just fainted, then gila we manusya vaadi karawanna. They get anoxia to the brain, right? Because when you kapate isuama, right? Brain negata perfusion, and they get a little bit of anoxia to the brain, which can give rise a little bit of seizure activity. Podda. A few myoclonic jerks can occur because of this cerebral anoxia. So that's why you say never try to sit up a patient who has had a syncopal episode. They can generate reflex anoxia, cerebral anoxia. So, so short-lasting myoclonic jerks are not necessarily suggestive of a seizure, right? They can be due to cerebral anoxia in vasovagal syncope. Right. Chamali halatino, incontinence occur with syncope. That's unusual, Chamali. Usually, if you get all of these are balanced, but if you get somebody coming with incontinence and seizure-like thing, you think it is a true seizure. Right. So this is very important. And when you're studying, I would ask you to go through this table in a little bit more detail. Right? Okay.
Sir, excuse me.
Yes, Imalka.
Sir, in this statement, they say short-lasting multifocal myoclonic jerks during the episode.
During the episode, they not puluwan vasovagal like statement, short-lasting myoclonic, multifocal myoclonic jerks. Those are very typical of vasovagal anoxic seizure features. Right?
Thank you, sir.
Okay. Right. Now, another very similar MCQ that you can be asked is about the difference between a seizure and a pseudo-seizure, right? Pseudo-seizure. Or pseudo-seizures are functional neurological disorders. Functional neurological disorders. We also call them a pseudo-seizure, right? Pseudo. So you need to know the differences between that as well. So I will just mention a few. Right? Now remember, pseudo-seizures will always occur when there is a crowd around, right? When there are people looking at the person. Now, when we have patients in the ward, we frequently see visiting hours. The episode occurs during when there are people around looking at the person, right? That's when this happens, right? Seizure, there is no specific circumstance for a true seizure. It can happen anywhere. Sometimes they happen during sleep also, right? But in a pseudo seizure, they happen when the patient when there are people around, people watching the person. Now also remember, pseudo seizures, the movements are large volume. Sort of thrashing of the limbs, pelvic thrusting, right? More large volume amplitude movements, right? And these are non-stereotypical. Non-stereotypical kind of pattern එකක් නෑ, right? Pattern එකක් නෑ. ඔහේ අත් ගහනවා එහාට මෙහෙට, pelvic thrusting, that sort of thing, right? And that would more suggest a functional neurological disorder, pseudo seizure, rather than a true seizure. True seizure, right? So the circumstance in which it occurs, and also the actual movements, the non-stereotypical, large amplitude, thrashing, pelvic thrusting sort of movements are more common in pseudo seizures. Right. Now, sometimes it can be very difficult to differentiate these two, and you might need to do something called a video EEG. Video EEG. Can patient a video karnawa, and if the episode happens, you can see if there are any EEG changes at the same time. So that's called a video EEG. Again, classification I have given here, right? And sometimes the classification of seizure types. Sometimes you can be asked certain things about specific seizure types, specific seizure types, right? And one type of seizure, which is a generalized seizure, is an absence seizure, right? It's type of generalized seizure, as you can see here in this classification scheme, right? An absence seizure, right? Okay. Now, absence seizures typically are not associated with any brain structural abnormalities. They are not. Typical absence seizures, what happens is the patient suddenly loses awareness for a period of time and is not associated with anything else. Nikan ara blank yano tappara ganakata vinadiyakata vitara, and then they come back. Right? They don't lose tone or fall or have any sort of motor problems, right? During that episode, right? During that episode. So that is another feature that you need to remember. Usually lasts for few seconds. These absence seizures are typically known to be precipitated by hyperventilation. So if you ask the patient to hyperventilate, it can trigger off seizures, right? Patient and it happens. When you ask them to hyperventilate, it precipitates absence seizures. Right? So these are some facts about absence seizures. So there is usually no structural brain abnormality. They have loss of consciousness, but don't lose tone, they don't fall, they don't have any other motor issues, and they are provoked by hyperventilation. And usually this typical EEG pattern, which is called a 3 Hz spike and wave pattern, make a pediatrics, right? This is what you see, right? No, obviously you are not supposed to interpret EEGs at your level. Postgraduate but this is generally what it looks like. Right? Yeah. So usually, Sajid, yes, these are usually noticed by other people. The person doesn't know, right? The person can't recall. Right. Hari, right. So 3 Hz spike and wave pattern on the EEG is supposed to be typical of this absence seizure, right? And I'll talk about treatment a little bit later on with all the anti-epileptic drugs. Hari? Right. Any questions up to now? You can get this sort of MCQ. Yes. Kian.
Prolactin level එකෙන් අපිට වෙන් කරගන්න පුළුවන් pseudo seizures.
මොකෙන්ද?
Prolactin level එකෙන්.
Yeah, so supposedly prolactin rises during a pseudo seizure. Right? But take එච්චරම හොඳ විදිහක් නෙවෙයි, prolactin කරගන්න ලේසි දෙයක් නෙවෙයි. Right? Okay. Hari. Right. Now, absent seizures, but treatment ගැන පස්සේ කියන but මෙතන MCQ එක තියෙන නිසා carbamazepine usually aggravates absent seizures. The typical thing we use is something called ethosuximide. That's a drug of choice, ethosuximide. Tatsaranis can absent seizure associated? Usually not. No, there is no preictal aura in absent seizure. Okay, fine. Make it atypical absence you need to know the features of a typical absence seizure. Okay. Now, as I told you, an epilepsy syndrome is a very specific diagnosis which has a very nice EEG, very nice clinical pattern, may have specific EEG patterns and specific neuroimaging patterns, MRI patterns. Now, in pediatrics, they would have taught you about some of these, right? Especially West syndrome, which is Professor Jitangi's pet topic. She has done a lot of research in West syndrome, and that is something that she would have taught you in pediatrics. In adults, the only thing that you might need to know of is something called juvenile myoclonic epilepsy, right? Juvenile myoclonic epilepsy, which has a very specific age of onset, very specific clinical feature. So 10 to 20 during adolescence, they present with myoclonic jerks, usually associated during waking up in the morning. And they may also have generalized tonic-clonic seizures. The EEG, there is a specific pattern, right? There is a very specific pattern on the EEG as well. So remember, epilepsy syndrome is nice specific clinical manifestation with some EEG changes which might be specific, and also MRI or radiological findings. This is what a typical EEG in juvenile myoclonic epilepsy looks like. Right? Nikan ආසාවට දාන්නේ මේව පාඩම් කරගන්න ඕනේ නෙවෙයි. Right. Okay. Right. Hari. Make own name. Forget about this. This is too complicated for you. Hari. Hari. Okay. Right. මොකද ඕගොල්ලෝගේ මෙච්චර details අහන්න එකක් නැහැ, I don't think. Right? This is again a very specific type of epilepsy syndrome, right? Where patients have hippocampal atrophy on MRI and present with temporal lobe onset focal seizures, right? MRI karam, you can see this hippocampal atrophy. So this is again another epilepsy syndrome. Epilepsy syndrome, right? Matakain epilepsy syndrome can specific clinical manifestation, EEG pattern, and MRI findings. So, mang dekaka nam kiwa, juvenile myoclonic epilepsy is one. West syndrome you know from pediatrics. And another thing we see in adults is this mesial temporal lobe epilepsy syndrome, right? Where there is associated hippocampal atrophy on the MRI. Okay, now how do you diagnose a seizure, right? I told you that clinical history is the most important thing, clinical history, and sometimes bystander history or eyewitness history. Remember that the EEG inter-ictally, that is in between episodes, is normal up to 60% of cases. So up to 60% of people are absolutely normal inter-ictal EEG. Inter-ictal EEG can when in between seizures, when they're just normal. EEG is also normal in up to 60% of people, right? So EEG can diagnose karanna bahe. Clinical history can thamai mostly diagnose karanna puluwan. But of course, you can do other very high-flown EEG methods, right? If the diagnosis is uncertain, I gave you an example of that video EEG. Sometimes it's very difficult to differentiate pseudo seizures from real seizures. It's extremely difficult to differentiate. You might use a video EEG, right? Imaging for patients with seizures and epilepsy is mostly for high-level management, right? Right? we do imaging only in a very selected set of patients. For example, they're not responding to medication. We do imaging, right? And you might have heard of epilepsy surgery also. You need to do imaging. So these are patients who are refractory to medication on about 5 or 6 anti-epileptic drugs that nothing works, right? You do imaging and surgery and that sort of area. But for a general thing, the history is the most important thing to diagnose a seizure and epilepsy. And remember that the EEG can be normal in about 60% of people when they don't have an episode. Right. So, ඒක මම අර පළවෙනි MCQ එකේ fifth statement එකට ආයි ගියොත් එහෙම ඒක අහලා තිබ්බා. හතරවෙනි statement එක here. EEG is abnormal in most patients with epilepsy. That's false. It's abnormal only about 40% of people. And එතන EEG කියලා මම refer කරන්නේ this interictal EEG, right? Right. Okay, right. Fine. Now, the next MCQ focuses a little bit on the treatment that we offer for patients with seizures and epilepsy. Right. And I'll just run you through this MCQ and we can discuss about the drugs a little bit more also. Right. I think there's another MCQ that talks about the medication. Yes. Right. Now, when you have a patient with a seizure, the first statement, patient should be commenced on anti-epileptic drugs following a single seizure. Right? Anti-epileptic drugs following a single seizure. Like a variety. We often don't do that. Right? We often don't start anti-epileptics following a single seizure. There is a reason for that. Right? There is a reason for that. The reason is this. If somebody has one seizure, their risk of getting another seizure, their risk of getting another seizure is actually less than 10% also in their lifetime. Obviously, if they have more seizures, the risk of recurrence is higher, but take a person who has come to you with one seizure. The risk of that person having another seizure is less than 10% in their whole life. So we don't usually start anti-epileptic drugs after a single seizure. Like all things in medicine, there are exceptions. What are the exceptions? First exception. If you can clearly diagnose an epilepsy syndrome, if you can clearly diagnose an epilepsy syndrome in a patient who presents with the first seizure, clearly diagnose karanna puluwanna, right? So there should be a very specific history, EEG and MRI, whatever story. If you can diagnose an epilepsy syndrome clearly and on the first seizure, yes, start an anti-epileptic because their risk of recurrence is much higher, right? So if you can do that. If there is evidence of structural brain damage, some structural focal problem in the brain following the first seizure, yes, also give them anti-epileptics because their risk of recurrence is also higher, right? So these are two indications where you might give anti-epileptics after the first seizure. So what are they? One, clear diagnosis of epilepsy syndrome. Two, if they have some structural brain abnormality in association with the seizure, those are two indications where you give anti-epileptics following the first seizure. The third indication, say somebody is doing a very high risk job or right? High risk job. Where if they have another seizure, they might die in they're doing that job. Right? Some are drivers or people who are in water related occupation, right? Also you would start anti-epileptics. Of course, you can't drive or do water related sports 1 to 2 years after, depending on the rules of the country. But generally 1 to 2 years after, you can't drive or do anything after a seizure, right? But in those sort of occupational related problems also, you might start anti-epileptics after a first seizure. So make NCQ වලට නිතර අහන දෙයක්. ඒක මතක තියාගන්න. So we don't usually put patients on anti-epileptics after a single seizure, except for those 3 conditions that I mentioned. Either there is some occupational thing, there's a structural brain abnormality, or there is some epilepsy syndrome that you can clearly diagnose. හරි එහෙම එකක් තියෙනවා නම් විතරයි අපි drugs පටන් ගන්න. හරි. Then the next important principle is monotherapy is preferred කියන එක පැහැදිලි. That's true. In anti-epileptic drug treatment, monotherapy is what you commonly give. එක drug එකයි දෙන්නේ. Okay. Right. Now let's talk about some of the drugs and come back to this MCQ. Right. Now, anti-epileptic medication, the mechanisms are complicated, but essentially what they do is they inhibit sodium and calcium channels and enhance inhibitory neurotransmitter activity. Makes sense? By blocking the sodium and calcium channels, they are stopping the neurons being excited. Neurons excite when you block the sodium and calcium receptors. And by enhancing the inhibitory neurotransmitters like GABA, that also stops this neuronal activity from propagating. Right. So that is the general mechanism of action. And of course, monotherapy is better. Right. So this table gives you the sort of commonly used drugs for each type of seizure. Right. මේකේ මම ඔයාලට මතක තියාගන්න දෙකක් කියන්නම්. එකක් තමයි in mostly focal sort of seizures, focal onset. මේක ලියා ගන්න. Anti-epileptic drugs ගැන 1. In focal onset seizures, carbamazepine is usually the first line drug. Carbamazepine in Sri Lanka, in focal onset seizures, we commonly use carbamazepine as the first line drug. In generalized seizures, currently lamotrigine is the preferred option. Lamotrigine is the preferred option. But we also use levetiracetam and topiramate. Lamotrigine, levetiracetam and topiramate. Lamotrigine is usually preferred. Valproate is going out of fashion now. Now, those days when I was a medical student, junior doctor, we used to use valproate for a lot of people. But valproate is going out of fashion. And especially you cannot use valproate now in females of childbearing age. That is very important. Valproate should not be used in females of childbearing age. Big no-no. Big no-no. Because of the teratogenic potential of valproate. Lamotrigine, topiramate, levetiracetam, all are safe in pregnancy. There is no problem. But valproate causes significant fetal abnormality. So you're not supposed to use it in females of childbearing age. That's confusing area. So if it's a focal seizure, go with carbamazepine as your first line option. If it's a generalized seizure, go with lamotrigine, levetiracetam, topiramate. But valproate is going out of fashion and should not be used in females of childbearing age. Right. I told you already that absent seizures, ethosuximide is the drug of choice. And in myoclonic seizures, I also have given you some drugs here. Remember that carbamazepine, it's also an MCQ point and practice point. Carbamazepine can worsen absent seizures. Carbamazepine can worsen myoclonic seizures. Right. That's a little bit about the anti-epileptic medication. And in this 5th question, statement 3 is false, because myoclonic seizures are worsened by carbamazepine. So we use valproate, lamotrigine. Right. Valproate is the first line drug for generalized tonic-clonic epilepsy in women of childbearing age. Is absolutely nonsense. ඒක වැරදි. Right? Absolute nonsense. ඒක වැරදි. Okay. Right. Now, the last thing I want to tell you about sort of therapeutics of epilepsy and seizures is, can you ever stop anti-epileptic medication? The answer is only in some people, not in everybody. Right? Some people. Especially people with epilepsy syndrome, we usually can never stop anti-epileptics. Right? People with epilepsy syndromes, we would never stop the anti-epileptics. Right? But in some people, you can stop anti-epileptics when they are seizure-free for some time, right? Usually 1 to 2 years, depending on the patient. Right? You can stop, but you can't stop anti-epileptics in all patients, right? Wean off karanna bad, right? So hatara වැරදි. එම wean off කරනකොටත් බොහොම පරිස්සමෙන්. Again, patients who, if they are on 2 drugs, you wean off one slowly, then the other one. So very, very slowly, tamai, you need to do all these things. Right? Okay. So that is about little bit about the treatment. Right. Okay. Any questions up now? Purna adishala teenawa lamotrigine usually Purna me valproate tamai denne myoclonic seizures walata usually. Lamotrigine, as far as I know, is not a problem, but I'll check on that. Right? Right. Okay. Fine.
Excuse me, sir.
Right. Any other questions?
Excuse me, sir.
Oh, Pulas, can.
Sir, then anti-epileptic drugs ගැන දීලා තියෙන අර slide එකේ සර් කියලා මේ දාලා තියෙන්නේ status හරි todsteriasis වගේ තියෙනවා නම් දෙන්න පුළුවන් මේ first එකේ නම දෙනවද විතර සර්?
ඒ single seizure එකෙන් පස්සේ දෙන්න පුළුවන් ඒවා but මම වැදගත් මේවා ටික තමයි කිව්වේ මුලින්ම. ඒ කියන්නේ මෙතන තව slide එක ටිකක් තියෙනවා but වැදගත් මේවා ටික තමයි කිව්වේ. හරි? ඒ ටික මතක තියාගන්න. තව තියෙනවා indications but ඒ ඔක්කොම මතක තියාගන්න බෑනේ. වැදගත් ටික තමයි කිව්වේ.
So atypical myoclonic drug of choice valproate out of question. Atypical absence myoclonic
atypical absence ඒවට ගැන වැඩි දැනගන්න ඕනේ නැහැ. myoclonic එකේ valproate with clobazam කියලා drug එකක් තියෙනවා. benzodiazepine. ඒ දෙක තමයි වැඩිපුර දෙන්නේ. හරිද? myoclonic කියලා. හරි? Oh, somebody is asked, Sajit has asked this question. Yes, clobazam is used in myoclonic seizures. Hari? Yes. Vikum mahala tiyanama, how should we change anti-seizure medication therapy during pregnancy? That is a bit of a complicated area. I won't go into that. Sorry. But remember, no valproate gavaking vat tiyanna ba. Also phenytoin langing vat yavanne. Right? Things like lamotrigine are safer. Topiramate is safer. Newer anti-epileptics are safer in pregnancy. එතනින් එහාට මුකුත් ඔක් ගැන කලබල වෙන්න එපා. These are very advanced areas. Right. Right. Now, question number 6 gives you some side effects of anti-epileptic medication. One table එකකුත් දීලා තියෙනවා නිකන් reference වලට. But මේ ටික තමයි වැඩිපුරම අපි සාමාන්‍යයෙන් අහන්න කැමති ඒවා ටික. Right. Right. ප්‍රශ්නයක් අහන්නද ගියේ කවුරු හරි? Okay. Adverse effects tika balamu. Lamotrigine, Stevens-Johnson syndrome. Hari. Now the other drug that causes Stevens-Johnson syndrome is carbamazepine. Right? So eka liya ganne. Right. Hari. Okay. Carbamazepine, another important side effect of carbamazepine is SIADH. SIADH. Valproate can cause pancreatitis, but the more important thing about valproate is that you need to know that it has a very high risk of fetal malformations. It also causes hair loss, right? Hair loss is another common side effect, right? Phenytoin sodium, the main problem with phenytoin sodium is causes coarseness of facial features, gum hyperplasia, right? Gingival hyperplasia, right? And topiramate causes weight loss and not weight gain. Most of the anti-epileptics tend to cause weight gain, but topiramate causes weight loss. Right? Topiramate causes weight loss. So MCQ I have also given you a more detailed table about all the side effects. But essentially, valproate not good for pregnancy, causes hair loss, weight gain. Hari kachal. Phenytoin also coarsening of facial features, gum hypertrophy, e wage dewal tamai enne. Fine. Okay. Any questions about seizures and epilepsy then? Levetiracetam myoclonic වලට මම හිතන්නේ දෙනවා කවුද චත්‍ර. Okay. Sajid, there are a long list of drugs that cause gingival hypertrophy. Anti-epileptic swelling, you need to know phenytoin. That is a famous one. Right? Okay. Right. Okay. So let's move on then to movement disorders. Now, obviously, in your lectures, I think Professor Chang does this lecture still. He would have taught you that the classification of movement disorders is into hyperkinetic disorders, right? Hyperkinetic disorders like tremor, chorea, and also hypokinetic disorders. Hypokinetic, where the movement is reduced. Movement is reduced, right? Hypokinetic, they are also called akinetic rigid syndromes, right? Same terminology, right? So hyperkinetic, hypokinetic, or akinetic rigid syndromes is the common classification. Right. Now, let's talk about Parkinson's. Now, follow this carefully because this classification is important. Now, Parkinsonism is a set of clinical manifestations. Parkinsonism is a set of clinical manifestations, right? What are the clinical manifestations? Tremor, rigidity, akinesia or bradykinesia, and postural instability. So these are the features that are common to Parkinsonism. So Parkinsonism is a clinical syndrome which is characterized by tremor, rigidity, akinesia or bradykinesia, and postural instability. That is Parkinsonism. Now, Parkinsonism can be secondary to various disorders. May localized to top two things are common: vascular disease or vascular Parkinsonism, second to strokes, for example, and drug induced, like antipsychotic induced, right? So Parkinsonism can arise due to secondary problems like vascular disease or drugs, right? And there are a whole lot of other secondary causes. Now, Parkinsonism can also be primary, right? Primary, right? And within the primary, you have idiopathic Parkinson's disease. Idiopathic Parkinson's is a common type of Parkinson's disease you would see. Idiopathic Parkinson's disease. But remember, there are lots of other atypical Parkinson's related disorders. Atypical Parkinson's related disorders, right? And some of these are called Parkinson's plus syndromes. මේ උඩ හතරක් තියෙන්නේ. 1 2 3 4 උඩ dementia, Lewy bodies, MSA, PSP අනමන ඒවා ඔක්කොම we also call Parkinson's plus syndromes. Parkinson's plus syndromes. So these are atypical Parkinsonism. මම atypical කියන්නේ ඇයි කියලා කියන්නම්. ඊගාවට in the next slide. Don't worry about all this long list. මම කම්මැලිකමට මේක යන්නකින් copy paste කරා මේ ඔක්කොම ඔයගොල්ලෝගේ ජීවිතේට අහන්නේ නැහැ. හරිද? Right, so that is the classification of Parkinson's. So Parkinsonism is a clinical syndrome. It's primary and secondary. Primary Parkinson's can be idiopathic Parkinson's disease, which is the common thing that you see, and also this Parkinson's plus or atypical Parkinson's syndromes. Right. Now, the pathology of Parkinson's is there are Lewy bodies, right, in the substantia nigra, right, which is in the midbrain and the basal ganglia region, right, Lewy bodies in the substantia nigra, right, that you see, right, and there is loss of dopaminergic neurons in these regions, loss of dopaminergic neurons. So what happens is there is an imbalance between dopamine and acetylcholine in these brain regions. Right? Dopamine, acetylcholine, put imbalance, right? Right, and you get these Lewy bodies in these regions. If you cut open a brain, for example. Right. And in these Lewy bodies, there is a substance called alpha-synuclein, which is deposited. And it is thought that alpha-synuclein is one of the important markers in the pathogenesis of the disease, right? Alpha-synuclein, the substance which is aggregated in the Lewy bodies, right? So in question 7, statement number 1 is true. Second one, yes, again, I have taught you now, just now, that what happens is there is degeneration of dopaminergic neurons in the substantia nigra. That is what you see. Now, in Parkinson's disease, this is the classical feature that you see, right? All of you know that they have a rest tremor, which is asymmetrical often, right? Asymmetrical. Asymmetrical rest tremor, right? Asymmetrical rest tremor, and it is a pill rolling tremor, right? They also have cogwheel rigidity and rigidity, right? Again, slightly asymmetrically. So in idiopathic Parkinson's disease, they typically present with a unilateral or asymmetrical rest tremor, not symmetrical. Symmetrical, right? And the rigidity is not clasp knife rigidity, it is cogwheel rigidity. Clasp knife rigidity occurs in upper motor neuron type lesions, right? In spasticity, right? In Parkinson's, what they have is a cogwheel rigidity. Clasp knife rigidity can have a pen knife sensation. Cogwheel rigidity is different. That is a different thing altogether. Right. Okay. Okay, good. Fine. Now, even though we talk a lot about motor symptoms in Parkinson's, motor symptoms like tremor, rigidity, akinesia, bradykinesia, postural instability, it is now recognized that there is a whole load of non-motor manifestations that also occur. Whole load of non-motor manifestations like GI problems, urinary problems, non-motor, sleep problems, lot of non-motor manifestations, right? Lot of non-motor manifestations. And it is now thought that non-motor manifestations can actually precede the motor manifestations. Non-motor manifestations can precede the motor manifestations. That's very important, right? Okay. Very important. Non-motor right? And somebody has done some very nice research showing that actually olfactory abnormalities are one of the earliest manifestations to occur in Parkinson's. Olfactory abnormalities, right? So this is very important then. So Parkinson's have a classification in the classical or idiopathic Parkinson's disease variety. They get bilateral but asymmetrical resting pill rolling tremor, rigidity, which is cogwheel, and Yasasvi has asked, yes, Yasasvi, there is also leg pipe rigidity, cogwheel rigidity, leg pipe rigidity, and then they have postural instability as well, and bradykinesia, right? And remember, non-motor manifestations are known to precede motor manifestations. Right? And olfactory abnormalities might be early markers of disease onset. Now, this is a little bit of a complicated table, but I will tell you the important ones. Right. Now, what are the features that go against idiopathic Parkinson's disease? Now, idiopathic Parkinson's disease is the common variety. Secondary Parkinson's, Parkinson's plus, there are certain features that go against the diagnosis of idiopathic Parkinson's. So, in a patient who comes with Parkinsonism, these are called red flags for the diagnosis of idiopathic common Parkinson's, classical Parkinson's disease. Right? What are these red flags? Right. මේ table එක බලන්න එපා මම කියන්නම් cutting මේ table එකේ තියෙනවා but මම cutting කියන්න. හරි. Number 1. Early onset dementia. Early onset. These are against the diagnosis of idiopathic Parkinson's in a patient who comes with Parkinsonism. Parkinson's features තියෙනවා but ඒක idiopathic නොවන හේතු ටික තමයි මේ කියන්නේ. Right. Number 1. Early onset dementia. Early onset dementia. You don't see that in idiopathic Parkinson's disease. Yes, Parkinson's disease patients do get dementia, but that's a late feature. Idiopathic Parkinson's dementia yes, but it is a late feature. If you have early dementia or dementia as the presentation, that is against idiopathic Parkinson's. Early dementia. Right. Number 2. Right? Frequent falls as the presentation. So, lot of postural instability that is dominating the presentation, causing frequent falls. That is also against idiopathic Parkinson's. And Hashir has asked that question also. Parkinson's and postural instability but not a lot, right? If they have frequent falls, excessive postural instability, that is against idiopathic right? Parkinson plus or secondary right? So early onset, MCQ to early onset dementia, frequent falls and significant postural instability, significant autonomic dysfunction. Significant autonomic dysfunction again is a red flag right? Parkinson plus syndrome significant autonomic abnormalities. Right? Other neurological manifestations like gaze palsies, ocular problems, cerebellar problems, corticospinal tract problems, right, are all suggestive of other types of Parkinson's, right? Other types of Parkinson's, right? Cerebellar problem, other neurological issues like cerebellar problems, gaze palsies, corticospinal tract dysfunction. Eva are features of sort of non-idiopathic right? Next one. Limited Parkinson's features. For example, the classical example of that is in vascular Parkinson's, the Parkinsonism is limited to the lower limbs. The Parkinsonism is limited to the lower limbs in vascular Parkinson's, right? The last one is response to levodopa. Response to levodopa. Idiopathic Parkinson's has a fantastic response to levodopa, right? Fantastic response to levodopa, but the others don't. So, Hansi, yes, all the gaze palsies are not features of idiopathic Parkinson's. Features, right? හරිනේ ඒ ටික ලියාගත්තා නේද? So early dementia, early frequent falls due to severe postural instability, autonomic dysfunction, other cerebellar features, other neurological features like cerebellar signs, එතකොට මොනවද corticospinal tract problems, ඒ වගේ දේවල්, all features of non-idiopathic අනිත් ಜಾති වල features, right? And also restricted Parkinson's to the lower limbs and also response to levodopa. All of these things are important when you're diagnosing idiopathic Parkinson's. Right? Okay, now let's go to question number 8 then. And then we'll give time for questions. So Shamali, non-motor manipulation precede event. Eka less clear, Chamali, we are not very sure. Yes, definitely they precede in Parkinson's, idiopathic. Parkinson's plus for a sure. Eka mama danne ne. I don't know. I don't think there's enough research to show that. Parkinson's plus hari chutta is a rare thing. Idiopathic Parkinson's, yes, definitely there is evidence to say that non-motor manifestations precede the motor manifestations. Sometimes by many years. සමහර අවුරුදු 5-10කට කලින් එනවා කියලා හොයාගෙන තියෙනවා. Right. Parkinson's early postural instability indicates an alternate diet. අනේ මෙතන මේ true false එක හරි idiopathic Parkinson's කියලා ලියා ගන්න. හරිද? අනේක sorry. So early postural instability, alternate diagnosis, yes. And remember in all these Parkinson plus අරක මේක there are lots of MRI changes also, like midbrain atrophy වගේ දේවල්. ඒවා idiopathic Parkinson's වල MRI එකේ ලොකු වෙනසක් පේන්නේ නැහැ. Right? Right. Okay. So these are some of the examples of Parkinson's plus වල imaging. මේ ලස්සන නිසා මේ පෙන්නන්නේ. හරිද? වැඩියම මහ ලොකු දෙයක් නැහැ. Sorry. මේ එකක් මේ. So there are MRI findings in these odd sort of Parkinson's things. හරි. කොහොමද? පොඩ්ඩක් ඉන්න. මේවා පාඩම් කරන්න එක ආසාවට පෙන්න පොඩි ආතල්ලෙකුත් තියෙන්න බෑ. මේක බලනකොට මේකට කියන්නේ හමින් බර්ඩ් සයින් කියලා. පේනද කුරුල්ලගේ බීක් එකයි ඔළුවයි. හමින් බර්ඩ් සයින් කියලා කියන්නේ මේකට. Make a hot cross bun. Christians would definitely know what hot cross bun is. This is called a hot cross bun sign. තවත් තියෙනවා eye of the tiger sign කියලා. ඒක අමුතු ඒවා තියෙනවා. Interesting. Mickey mouse sign කියලා එකක් තියෙනවා. ඒක තියෙනවා. These are all non-idiopathic, the other varieties of Parkinson's and MRI findings. Okay. Now in this table again, මේක විභාගයට යන්න කලින් බලාගෙන යන්න ඕන එකක්. I have given you a summary of all the anti-Parkinson's medication, right? Anti-Parkinson's medication, right? And commonly now what we use are these dopamine agonists and levodopa. Or we commonly පාවිච්චි කරන්නේ as initial therapy, right? Initial therapy. Anticholinergics like benzexol have a better action on tremor, right? Dopamine agonists and levodopa mostly bradykinesia වලට තමයි, and dopamine agonists are used as early therapy in most people now. හරි මේවා ගොඩක් අපි පාවිච්චි කරනවා දැන්. දැන් අපි MCQ එකට යන්. Dopamine agonist therapy is effective at modifying the progression of the disease කියන එක ටිකක් controversial MCQ එක අතරම හොඳ නැහැ, ඒක දාන්න එපා. At the moment, none of the anti-Parkinson's medication have clear benefit of disease modifying capabilities. එහෙම මතක තියාගන්නකො. හරි. එහෙම disease modifying capabilities නැහැ. ගොඩක් ඒවා වල. Progression එක හොඳ කරන්නේ නැහැ. Most of these are just symptom management medications. Right. මෙතන හතරවෙනි එක anticholinergics are used for tremor, mainly for tremor කියලා අපි කිව්වා. ඒතර එක මතක තියාගන්නකො මම drugs ගැන main points ටික කියන්නම්. First line drugs are usually dopamine agonists and levodopa. And remember, idiopathic Parkinson's has an excellent response to levodopa. Anticholinergics like benzexol are mostly used for management of tremor, right? Mostly used for management of tremor. ඔය dopamine agonists වල අමුතු side effect set එකක් තියෙනවා. ඒ ටික චුට්ටක් බලා ගන්න. මේ impulse control disorders. That's a very unusual side effect of dopamine agonists and hallucinations. Right? ඔන්න අමුතු ඒවා ටිකක් තියෙනවා. ඒ ටික මතක තියාගන්න. Impulse control disorders කියන්නේ සූදු කෙලින්න එක පාට patient යනවා. Gambling. Right? Excessive gambling වගේ දේවල් වලට ලෙඩා යනවා. That's an unusual side effect of dopamine. ඔබට ඕන ලේසියෙන් මතක තියාගන්න පුළුවන්. මොකද ඔය අමුතු අමුතුව මතක හිටිනවා මේ දවස්වල විශේෂයෙන්. Right? ඒවා. Levodopa වල main ප්‍රශ්නේ තමයි මේ dyskinesia. That is the main problem. අර movement එක වැඩි වෙනවා. Movement එක වැඩි වෙනවා. Right? Movement එක වැඩි වෙනවා. Right. Chatra, slowing the progression and disease modifying are two different things. Disease modifying කියන්නේ හොඳ කරන්න පුළුවන් or complication එන එක නවත්තන්න පුළුවන් ඒ වගේ එකක් ඒ කියන්නේ. හරි? Like disease modifying anti rheumatoid drugs නේ ඒ වගේ දේවල්. Those are two different things. Right. එතන මේ පස්වෙනි එක හරි impulse control. එතන මේ table එක පොඩ්ඩක් බලන්න දැන් පොඩ්ඩක් ඔලුවට දාගන්න දැම්ම මේක ආයි පාඩම් කර ඉන්න නැතුව මේ යට තියෙන දෙක බොහොම කලාතුරකින් පාවිච්චි කරන්න. main තුන තමයි dopamine agonist, levodopa and benzsexual. Those are the three commonly used drugs. And the side effects චුට්ටක් බතේ තියන්න. Important side effect of dopamine agonists are අමුතු එක මතක තියාගන්න impulse control disorders. In levodopa, the main problem is dyskinesia. Some have GI side effects. The most common problem is dyskinesia. Again, abnormal movements. ඒකට ඕනට වැඩිය movements ඊගාවට ඒක දුන්න ගමන් dyskinesia. හරි. Okay. මේක ටිකක් advanced. දැන් මේ හදිස්සිය මේක ගැන ලොකුවට දැනගන්න ඕනේ නැහැ. Right? Remember, levodopa is effective for all patients. There was a question or a concern that it accelerates disease activity. That is nonsense. That's no longer accepted. But sometimes we prefer dopamine agonists in younger people. සමහර වෙලාවට මේක එච්චරම වැදගත් නෑ මේ ස්ලයිඩ් එකේ තියෙනක ඕගොල්ලන්ට එච්චර වැදගත්. හරි. And neither is this. Only thing you need to remember, in advanced Parkinson's, the disease is very difficult to manage. The drugs are very difficult to titrate. Hari amaru manage karana. Okay. Any questions about Parkinson's? Advanced PD ගැන undergraduates ලා ලොකුවට දැනගන්න ඕනේ. Only thing you need to know is it's difficult to manage. Very difficult to manage. And we use some of these unusual drugs in those states. Common three drugs are dopamine agonists, levodopa and benzsexual. ප්‍රශ්න තියෙනවද ඒ සම්බන්ධව මොනවද? Any questions? Right. So let's move on to the other sort of movement disorders. Chorea. Then chorea ගැන අහන්න පුළුවන් එකම එක list එකක් දීලා අහන්න පුළුවන්. What are the following causes chorea? මෙතන මම හිතන්නේ ඔක්කොම ටික හරි. හරි? Yes. Everything is correct here. මෙතන yes. හරිනේ. ඔක්කොම ටික හරි. ඒ වගේ ලිස්ටුවක් බලා ගන්න. Now this is a very important thing. මේ table එක බොහොම වැදගත්. මොකද මේක clinical වලටත් අහන්න පුළුවන් in some states. මොකද සමහරවිට we have given ඒක කියන්න fair, but Parkinson's is for short cases also. Upper limb examine කරන්න කියලා සමහරලාට දෙනවා. ලෙඩ හොයාගන්න බැරි වුණා. හරිද? I think ටිකක් අමුතු සමහරලාට පැටලෙන්න පුළුවන්. Right. Now here there are significant differences between Parkinson's tremor and essential tremor. Essential tremor. Hari? Essential tremor is an action tremor. Action tremor. Parkinson's is a rest tremor. Right? Essential tremor is an action tremor. Parkinson's is a rest tremor. all of you know that alcohol බිව්වම essential tremor අඩු වෙනවා. ඒක ඉතින් මතක තියෙනවා ගොඩක් අයට ඒක සාමාන්‍යයෙන්. Right? But it gets worse when you are angry or you're excited. නේ? You drink caffeine or smoke cigarettes ඒ වගේ වුණාම ගැස්සෙන්න වැඩි. Right. And also head tremor is associated quite a lot with essential tremor. Right? Parkinson's වල head tremor එක unusual, but you can get a little bit of chin, lip and jaw tremor. Right? පොඩ්ඩක් එන්න පුළුවන්. So these are some of the main differences between the two. Now, this question 10 gives you some facts about essential tremor. Autosomal dominant inheritance එකක් තමයි තියෙන්නේ. Right? So it goes in families and is autosomal dominant. Right? And manifests in adolescents and young adults. Rest tremor එකක් නෙවෙයි එන්නේ action tremor එකක් or intention tremor එකක්. Alcohol reduces essential tremor, and propranolol is a common drug we use in the management. Propranolol. Propranolol ට හරියන තැන topiramate උත් දෙන වෙලාවල් තියෙනවා. Right. So those are all about movement disorders. Any questions now? Okay. Hari. So today we have discussed the theory behind seizures, epilepsy, and movement disorders. And we are now going to talk about, these are a few best response MCQs. Now, if you read this question, it will tell you that there is generalized tonic-clonic, weight, another hair loss. So this patient is on valproate, which is a big no-no. ප්‍රශ්නේ උත්තරේ valproate නේ, weight loss වෙන එක, weight gain and hair loss. එතකොට ඒක හොඳ නැහැ. In this patient, valproate තමයි beta. I would immediately wean off the valproate. එකපාරට නවත්තන්න බෑ. Remember, I told you that. එකපාරට නවත්තන්න බෑ. Wean it off and put the patient on something like lamotrigine. Because, as I told you very clearly, valproate is contraindicated in females of childbearing age. මෙතන උත්තරේ නම් valproate. මේක හොඳ බෙහෙතක් නෙවෙයි. මෙතනත් මේ valproate කතාවක් තියෙනවා. මේක ඇත්තටම පොඩ්ඩක් පරණ MCQ එකක්. ඒක ඉග්නෝර් කරන්න. හරි. Right. That is all. Right. Okay. Any questions? So today we have discussed seizures. I have given you the definition of seizures, classification of seizures, and when you diagnose an epilepsy syndrome. Hari, අපි etiology ගැන කතා කරා. Differential diagnosis of seizures is an important topic. How you differentiate syncope from seizures, how you differentiate pseudo seizures from seizures, those sort of things are important. And I gave you some common facts, important MCQ theory facts about certain types of seizures and certain types of epilepsy syndromes. Diagnosis of seizures is clinical, EEG can help, right? And then anti-epileptic drugs are common mechanisms I went through, and also give you some important facts about when to use certain types of anti-epileptic medication and when to start anti-epileptic medication. There are very specific circumstances where you give it after the first seizure. Movement disorders and side effects also of these anti-epileptic medications we went through. Movement disorders can be kata kara, Parkinson's, what are the sort of red flags or unusual things to look for when you're diagnosing Parkinson's, right? Things that suggest an alternate diagnosis to idiopathic Parkinson's. And drugs I went through, important medication, and finally we ended off with some other movement disorders. Hi. Any questions?
So then me valproate me contraceptive එකක් එක්කවත් දෙන්නේ නැද්ද female?
Then it's not recommended. Now, for example, in the UK to use valproate, you have to get permission from the pharmacologist. මෙහෙර වෙනම ඉන්නනේ pharmacy specialist ලා. ඒක වෙනම form 10ක් විතර දෙනවා පුරවන්න. ඒක ගන්න very restricted. සමහර වෙලාවට දෙනවා. resistant epilepsy වල වගේ, but it's going out of practice. ලංකාවේ තාම දෙනවා because lamotrigine is very expensive, but it should be avoided in females of childbearing age whenever possible. Well, contraception is not 100% fail safe. Sarangani, then shall we call it a day and do on Sunday? Sunday we'll finish neurology and then we'll go to endocrinology, which is reasonable because that is the other big area. So
Okay.
then if we can finish that off, the other ones are small things. Nephrology or podi now we remind me, we have done cardiology, respiratory medicine, gastroenterology, and now neurology. We can finish endocrinology. So that will be